All right, good morning. We're going to go ahead and get started since it's 7 o'clock. I don't know what I picked up, but I'm a little under the weather. That's why I was wearing my mask. So I'm going to try to stay away from everyone and get home as soon as this is done. Our first speaker is Dr. Nick Cost. As all of you know, he will discuss relevant issues in childhood cancer survivorship and why surgeons should be involved. Nick Cost has a very, very interesting educational and experiential past. He received his Bachelor of Science from Vanderbilt, then went on to get his MD at Emory, and then did some very, very high-level clinical oncologic urology fellowships as well as scientific fellowships. And these were at University of Texas Southwest, as well as University of Cincinnati College of Medicine. And since he's come here, he has really helped with others in our department and in the urology division and at Children's Hospital to really propel the pediatric urologic oncology service. And in fact, after a very wide international search, he has just been named the director of children's pediatric urology. So, he's definitely the quadruple threat, great clinician, extremely well published, grants, and a well sought after teacher. And with that, Nick, I'm not going to shake your hand, but welcome to the podium.
All right. Well, thank you all. The handful of times that I've had the opportunity to present here, the introductions from Dr. Schulich are always one of those things you'd like to bottle to listen to again on your rough days. So again, what I'd like to speak about today is childhood cancer survivorship, an area that I do focus on. And sometimes it's not inherently clear why as surgeons we should be involved in that. But I think often, whether it's childhood cancer, or adults with cancer, the surgeon's the first person to interact with those patients. And so I'll go into a little bit about what I think the value is in terms of us starting from the very beginning, setting an expectation that the patients will survive and that survivorship journey then starts actually from the day of diagnosis. This is not intended to be overly formal, so if you have any comments or questions, please feel free to interrupt. As far as disclosures, I should mention my wife works as a senior medical officer for Janssen. They obviously make cancer therapeutics, but that is not the topic of my discussion today. And then I do serve as the chair for the Children's Oncology Group Renal Tumor Committee. We'll speak a bit about renal tumor issues in children, but in speaking today, I'm really expressing my own opinions and not that of the Children's Oncology Group. But what I'd hope for us to get through today and the points I'd like to get across are identifying what are the most common issues that children that survive cancer have, and specifically which patients are at risk for which specifically it affects, and understanding how discussing survivorship from the very beginning can be helpful, and then how they enter screening, and not necessarily screening for recurrence of cancer, right? But in this case, screening for problems that may come up because of their treatment. And then I will mention why as surgeons, I think it's important that we're part of that team. I should disclose, I do like dad jokes. I tend to use them to break up my talks because I think that people often lose a little bit of concentration every 5 or 10 minutes. So I'll try to jolt people back with a joke. This is one of my kids' current favorites. So you may have heard the Norwegian Navy is currently putting barcodes on all of their boats. And that's because when they come back into port, they can Scandinavian. All right. So why are we discussing this? Fortunately, because the treatment for childhood cancer has continued to get better and better, we now see more and more adults that survive childhood cancer. When you talk about the impact, and this slide's a bit old, coming from the St. Jude's Childhood Cancer Survivorship Initiative, there's probably over 500,000 adults now that are childhood cancer survivors. And that has big impacts on almost every medical intervention you would do. You'd have to look back to understand what have they had done, whether that's a surgery or whether it's radiation or chemotherapy. And so we're talking about a growing population of patients. And also, it's not just that they survive and then they go on to have a totally normal life. Over 80% of childhood cancer survivors in the next few years will have some sort of life-threatening illness, and that 95% of them will have a chronic illness. And so they really push this idea that survivorship starts from the day they're diagnosed. But you may say, in this case, I'm just a urologist or I'm just, XYZ surgical specialist. Like, why should I care about that? In my case, I care about the kidneys, may care about the bladder, the genitalia. But I would say there are a lot of other relevant organ systems that interact with maybe what we primarily care about. So in urology, we think about kidney function. We think about endocrine function and how that impacts so many of the other things that we take care of. We think about gonadal function and fertility. That's a big part of what we'll talk about today. And then again, metabolism, urinary stone disease, sexual function, obviously an important issue of people's lives, and becoming its own area of specialty in terms within cancer survivorship is how patients that are childhood cancer survivors have normal sexual function later on. And so I would say that this could logically apply to any part of surgery that you're involved in, specifically surgical oncology. I think it's important because as surgical oncologists, we often think of ourselves as part of that team, right? We're not just, the technician that gets called in to do this small, minute part. We really want to be part of the team. We may not deliver the chemotherapy, we may not deliver the radiation, but we want to be knowledgeable about it. And I would say survivorship now is part of that multidisciplinary cancer care. And so I think that we want to strive to be comprehensive providers and not just technicians. And I'm confident that many of you would agree with that philosophy. So, I will bring this back again to my own practice, but I think about the potentially morbid therapy that the patients that I take care of have. So Wilms tumor is one of the more common things we'll see in pediatric urologic oncology. These children all get chemotherapy, essentially. Specifically, many of them get doxorubicin that has late effect cardiac toxicity. We'll talk more about that. Also, many of them get radiation, and there's increasing evidence that even at fairly low doses of radiation exposure in childhood, they go on to have increased risks of side effects later in life. Pelvic rhabdomyosarcomas, again, they all get chemotherapy. Cyclophosphamide being a key part of the chemotherapy they get, and that has a number of long-term toxicities, specifically for gonadal function. It doesn't take much cyclophosphamide exposure to have a risk for both endocrine and fertility gonadal dysfunction. And then again, many of them get radiation. In this case, for pelvic GU rhabdomyosarcomas, talk about the terrible side effects that can cause. Also, if we do the surgery in these cases with pelvic exonerations, it's not hard to think about how that impacts their long-term life, both with intestinal diversions, sexual function after removing some of their pelvic organs. And then testicular cancer, again, the chemotherapies that many of them will get, and then the surgery itself, in this case, removing a testicle, how that impacts gonadal function, fertility, and potentially with related retroperitoneal surgery, ejaculatory dysfunction. But you may say, well, I don't really care for any of those parts of the body. I focus on these other areas, but there are a variety of other things that could end up at your doorstep, right? Orthopedic surgeons are dealing with some of these children that are exposed to radiation, whether that be flank radiation that's causing severe scoliosis and they're having spine surgery, spine issues, whether that's pelvic growth issues. We talked about radiation for pelvic rhabdomyosarcomas. It can be very dramatic to see sometimes these adolescents who had pelvic radiation at a young age. They'll continue to grow in general, but they'll have a frozen pelvis that's at the size of a 3 or a 4-year-old. Congenital cardiac surgery. So we talk about maybe even a quarter of the children that receive doxorubicin will go on to have early CHF. And this can be very dramatic, requiring obviously even cardiac transplant. Head and neck surgeons, there are a variety of aerodigestive issues related to the radiation that children may get. And then the abdominal radiation, abdominal surgeries that these children may repeatedly get, obviously later in life lead to secondary issues. And then GYN, we've alluded a little bit already to the fact that gonadal function can be greatly affected by both the chemotherapy and radiation that many of these children will receive. And so I think it's a logical leap to go from, well, we're going to screen to see if these children have problems to what can we do for them. And again, I would argue that we as surgeons should be involved in that process from the very beginning. And it's important to understand that the way that we screen these children is based on what we expect their risks to be. But there are some cornerstones for how we do this. So it's lifelong. It's not something like, well, we'll screen to see if you have a side effect for 5 years and then we won't do it anymore. It also requires a coordinated continuity of care, meaning that in these survivorship clinics, there's often a variety of providers. It's really not just led by the oncologist, but there's all different kinds of specialists that are involved. And again, I would argue as surgeons, we should be part of that. It's also comprehensive. So it doesn't just end at, the physical health, but also a big part of it is the long-term mental health burden that this can cause. And again, as I mentioned, healthcare of the whole person and not just the physical medical needs. So there are a variety of really good recommendations that have been put together by very thoughtful people from a variety of different organizations, including the NCCN, also the Children's Oncology Group. They've put a lot of thought into this. And so the guidelines that we'll go through from here on out are really based on those two organizations. But again, as I promised, another dad joke. And again, as a urologist, this one is particularly pertinent. So what would you call a cheap circumcision? Well, naturally, that's a ripoff. So as far as areas that we focus on specifically, as you can see here, this is essentially the entire body from head to toe and including their mental health. We'll go through a few of these in depth, the ones that are probably more impacted. So visual function, this is something that you may not think of right off the top of your head, but especially children that are getting any sort of head or neck radiation. Up to a quarter of childhood cancer survivors across the board, though, will have some sort of auditory or ocular complications during the first decade after treatment. And so some of the most common ocular complications would be like early age of conditions we would consider older patients to have, such as cataracts and glaucoma. And specifically, the reason why this becomes a problem is because a lot of children start their cancer therapy with glucocorticoids. And then also, think about brain tumors with cranial radiation. So a number of these children have both of these risk factors and can go on to develop ocular issues. So they do screen children with visual function screening every year. And they specifically recommend looking for lens opacity and fundoscopic exam. As far as hearing, we talked a little bit about that already, but when we're within the testicular cancer community, we use a lot of cisplatin, and we know the long-term effects of tinnitus in those patients. And so platinum-based chemotherapy specifically is a big risk factor for auditory dysfunction later in life. Also radiation and some of the other kind of supportive medications that often these patients will get, including aminoglycosides and loop diuretics. But the platinum-based chemotherapy can really impact tinnitus, meaning, the ringing in the ears, but also can lead to permanent hearing loss. And this is really more cisplatin than carboplatin. And for that reason, there have actually been some efforts within both gynecologic and urologic oncology in certain cases to be able to use carboplatin rather than cisplatin. So they do recommend screening these children every year, especially if they've had cisplatin of any dose, and then carboplatin only if they've gotten usually at part of a bone marrow transplant regimen. As far as pulmonary function, again, this is another common area for long-term problems. This is usually due to radiation for the whole lung and also certain chemotherapies such as bleomycin. And what's really striking is that those children that are cancer survivors, they have a really increased excess risk of having mortality related to pulmonary complications. And this is only second to the deaths that we see from second malignant neoplasms. And the pulmonary function continually is impacted, meaning it's cumulative, so that over time they accumulate more and more risk to having long-term problems. And so we screen these children that have been exposed to some of these risk factors, and we'll do an annual exam, obviously, but also prompting specific symptoms. Also, we really counsel them specifically around avoiding smoke exposure and other things that may be dangerous. As for example, scuba diving, children that have cancer who have been exposed to these things need to have medical clearance. Cardiovascular function. So doxorubicin or anthracyclines are one of the most common anti-neoplastic chemotherapies that we give children. And so up to 2/3 essentially of children that have had doxorubicin or have had radiation to the chest will go on to have some sort of diminished cardiac function. And some of the risk factors, again, include increasing toxicity from the anthracycline or having concurrent radiation of the chest, especially when they're younger. And so these things, for example, all scream for the child with Wilms tumor that's going to get doxorubicin, that's going to get whole lung radiation for lung metastases, and that are going to be under 5 years of age, especially the female patients. And so we are very, very thoughtful about long-term cardiac toxicity in that patient population. So we're trying to do things to avoid that. So for example, we're limiting the anthracycline that we're giving to these children now. We've developed novel radiation approaches where they can do cardiac sparing, whole lung radiation. And there's also kind of protective agents such as dexrazoxane or Zinacard. That's a chelator of the intracellular iron that we believe causes the long-term cardiac toxicity. We also screen these children that are at risk, and they'll get an echocardiogram both at diagnosis and then during follow-up, and then even periodically later in life. As far as GI function, a lot of times we think about this mostly as the acute toxicity. So during the period of abdominal radiation or during chemotherapy, obviously there's quite a bit of GI toxicity. However, there are certain chemotherapies that can cause veno-occlusive disease that can cause hepatic toxicity that's life-threatening. Also, the radiation that these children get cause long-term GI side effects, both in their function, but also for a neoplastic risk. There was recently a paper that came out that looked at the cumulative risk of developing colorectal cancer from even relatively low doses of radiation in childhood. So we're talking about radiation doses as low as maybe 10 gray, that these children go on to have an increased risk of colorectal cancer that may be 3 times higher than age-matched children that didn't have this exposure. As far as renal function, there's a variety of things that we can do that may diminish renal function in childhood cancer survivors. One of them being taking out one of their kidneys, but then also many of the chemotherapies as well as the radiation that they get can impact the kidney's function. The things specifically that we worry about most are doses of radiation greater than 15 gray, and then higher doses of cisplatin and ifosfamide. A common theme is the exposure seems to be related to age in the sense that if they're exposed to these things earlier in life, they're more likely to have long-term dysfunction. So we do screen childhood cancer survivors looking at both their renal function with labs, but also with blood pressures and urinalyses. We more and more get nephrology involved early in following these children. Also, we counsel them about exposure to risk factors later in life, such as avoiding NSAIDs. Bladder toxicity, this is something as urologists we get called about not uncommonly, but during the course of chemotherapy with some of the specific agents, hemorrhagic cystitis is a problem, and then long-term risks for bladder cancer due to exposure, usually to cyclophosphamide. Also, pelvic radiation can be part of this picture as well. What's really sad is when you add the combined things we know cause bladder cancer, such as exposure to tobacco, we see risk-taking behaviors a lot with childhood cancer survivors. So we do have to spend a lot of time speaking with them about avoiding things like smoking or excessive alcohol or drug use. But we do screen them for symptoms as well as urinalyses to look for microscopic hematuria. And we will get referrals for this based on having either gross hematuria or repeated microscopic hematuria. We spoke a bit at the beginning about gonadal function, and that's both the endocrine function as well as the fertility. And I think that this is the area that we're probably seeing the most movement in terms of survivorship these days. But for males, it's a slightly different picture than the female cancer survivors. So when the testicular function, the fertility function is not nearly as hardy as the endocrine function. So chemotherapies or radiation are much more likely to impact the ability of the testis to produce sperm, while the testosterone production is usually retained. However, even at very low doses of radiation, that can be impacted. The chemotherapies that we think about most specifically are cyclophosphamide and cisplatin. And there are certain threshold doses that we think about, for example, 7.5 grams per meter squared for cyclophosphamide, we consider a threshold dose for causing infertility in males. However, kind of no dose is safe. And on the flip side, some patients that have really high doses of exposure also go on to still be able to have children. The problem is that you don't know that at the time of diagnosis. And so really your only time to intervene is before they've been exposed at all. So we are pushing more and more for fertility preservation counseling before treatment. I see Dr. Corkum here in the room. She works with us in our surgical oncology program at Children's and a variety of areas, but fertility preservation is something that she's very passionate about, has worked to develop a very strong fertility preservation team. there at Children's. And really the keystone of that is getting involved early, as I've mentioned. But we will screen these children later after they've gone through their treatment. And that has to do with both questionnaires, but also some lab-based evaluations. All right, so another quick dad joke. So have you heard about the mathematician who was afraid of negative numbers? They'll stop at nothing to avoid them. All right, for the female patients, it's a slightly different picture because of the way that the ovarian follicles develop. So relatively, their fertility function can be impacted a bit differently. But again, we think about the same kind of risk factors such as radiation and alkylating chemotherapy, as well as basically unlike with the male patients where you're going to see a differential based on the exposure, you tend to see in the female patients them experience more endocrine ovarian failure later. And that increases as they get older. And so we spend more time with the female cancer survivors screening for their endocrine function as they go on. The ovaries of the younger female patients are a bit more radio resistant than the older patients. And so we have slightly different threshold doses. And because they develop their follicles earlier on, the way that the gametogenesis happens, essentially they're more resistant to some of the exposures, both from chemotherapy and radiation. But we do start with fertility counseling before they ever get treatment, and then go on to screen them throughout the rest of their life. Second, malignant neoplasms, we alluded to a little bit beforehand, but this is the biggest cause of death for childhood cancer survivors, and up until they start to experience kind of the more normal age-appropriate causes of death. And there's really two types of secondary malignant neoplasms that we see in childhood cancer survivors. They accumulate over life, meaning that they continue to increase, and they can be quite high, such that up to 10% of childhood cancer survivors will have a second cancer within the first 10 years, the first 30 years. And these are generally most commonly non-melanoma skin cancers, but can be a variety of different malignancies. As I mentioned, the two different types, you have a myeloid-based secondary leukemia that can occur that's unfortunately very resistant to therapy, but is most closely associated with alkylating agents and topoisomerase inhibitors. And then you have the secondary malignant neoplasms that are more likely related to radiation exposure, and those tend to happen later, more likely to either be carcinomas or sarcomas. So we do screen patients specifically for a few of these things. So for leukemias and hematologic issues, obviously they're prompting questions about that, checking CBCs, doing certain kinds of high-risk exams, breast exams, thyroid exams, skin exams. But then also we're screening more and more for tumor predisposition syndromes. There's some really striking numbers that are coming out that you look at, for example, rhabdomyosarcoma patients that are under the age of 3. It may be that a third of those have a predisposition syndrome such as Li-Fraumeni. So that's becoming part of their survivorship screening, really, is to determine, do they have a genetic risk that they may go on to develop another cancer. For a couple of the specific cancers, breast cancer screening, we do see that happen earlier in these female cancer survivors. And so we recommend annual exams and then also earlier radiologic screening. And then for colorectal screening, as I mentioned earlier, we're starting to see a higher risk of colorectal cancer in those childhood cancer survivors that have gotten abdominal radiation. And so we start their colonoscopy screening earlier. So how does this relate to pediatric cancer survivors? I think there's some common themes that are run through any of the diagnoses that they may have. And one of those being psychosocial stress. Other is general quality of life. You can imagine that all of these ongoing screenings impact their ability to feel normal. And then also during adolescence, which is a very stressful time. My oldest son is going through all this right now. It's a difficult time to feel in any way different. And then especially when you layer on top of that, as you're coming into your own, as far as you're becoming a young man, becoming a young woman, how the loss or impact on fertility or gonadal function may impact that. All right, so I think this is one of my last dad jokes, but you may know dogs can't operate MRI machines, but cats can. So how do I study survivorship as a urologist? I think when you first bring this topic in front of a group of surgeons, they may not seem like it's a logical topic. But when I kind of first developed this talk and we're giving it to urology residents and urology trainees, we thought about, we spent a lot of time in urology thinking about renal sparing surgeries. And nephron sparing surgery is a classic example of survivorship research. Also bladder function, pelvic organ function, the impact that radiation and cyclophosphamide may have on that. And there's even a colleague of ours in pediatric urology who's R01 funded to look at this specifically, the impact of fertility from osteosarcoma treatment. So I mean, this is important work and things that, again, if you start to put yourself in that mindset of being a multidisciplinary provider, you can think of ways that you may be involved in survivorship research. And I'll just put in a shameless plug for how I kind of got involved in this area. And so, my personal interest was in things like kidney tumors and taking care of children that needed nephrectomies. But, as you start your practice, the oncologists don't just call about that sort of thing, but they also tend to call when they have a child that may have difficulty voiding. And so I started to think about how could those things be intertwined. And we thought about how the normal lower urinary tract function may be impacted by things that may infect the nerves or the muscles. And so chemotherapy can impact both of those. The slide here just showing that the common reasons why we see children have lower urinary tract dysfunction are usually because of neurogenic or myotoxic effects. And so I started to think about, well, are these children that are getting chemotherapy, is that impacting their lower urinary tract? So we thought about vincristine that we know impacts their peripheral neuropathies, and then doxorubicin, as we've already talked about, causing myotoxicity. And so we started to look at, well, maybe anthracyclines could also cause bladder dysfunction. Here's a kind of a force curve where you can look at increasing doses on the cardiac muscle of how increasing doses of doxorubicin may impact the force that a cardiac myocyte can generate. And so when we started down this investigative pathway, we looked at bladder strips, the muscular bladder strips, and saw how increasing doses of doxorubicin may impact mice that are exposed to these therapies. And you can see it's very similar in terms of the way that the doxorubicin decreases the ability of the bladder muscle to generate a force. And so again, this was not an area I was ever necessarily planning on going into, but as you started to take care of these patients in a comprehensive way, you come and you start to see some of the side effects that even the treatments that maybe you're not giving may have on these patients. And so how can we interact and intervene in a positive way? So I know our time is coming up short, so I'll stop it there. I do want to thank the people that I get to work with that help me do all of the research in this area, both in the lab and in the clinic, and then the mentors that I've had that have helped me along the way. We'll squeeze in one last dad joke that's my favorite. So why did Mozart hate chickens? And that's because they were always going on about Bach, Bach, Bach. So children are surviving cancer at a high rate, and that's great news, but it does mean that we need to do more when it comes to survivorship. And so I would encourage us as surgeons to have an active role in doing this, being part of the conversation, and remembering that medicine is a team sport, and none of us want to be just a singular athlete out there without the team around us. So thank you. I appreciate the time and your attention.
As I've been doing this for several decades, I actually recognized being treatment of the cancers that people come to me as an adult.
Yep.
Whatever cancer they have. Really important. We have time for one question or comment.
Dr. Potts, I remember well sitting in my office when you were interviewed for your position several years ago. You said, I think because I think I know, because I both trained in pediatric urology and adult urologic oncology, that I can see the connection between pediatric cancers and adult cancers and transition between the two. If someone were to leave here, one of the patients who is a pediatric cancer survivor, go to someplace far away, don't have access to all of this teams, really just being treated by someone who doesn't have a lot of experience in this area, how do they feel, how do they stay connected into a source of information that they can relate to their ongoing providers about what the risks are and follow should be? How would that be managed?
Yeah, it's a great question. Increasingly large medical centers are going to have these kinds of survivorship clinics. Obviously, we have one at Children's. There's one at the university that helps them through that transition and continues to follow them in adulthood. But when we do have patients that are going to leave and go somewhere else where they don't have that really rigid structure, we've developed basically educational materials that they can take and go educate their own PCP wherever they are about, okay, these are the things that I need. And so we have to kind of empower the patient so that they can then go empower their PCP. You can imagine though, the really difficult part in that is that many times these patients that are leaving in that way are leaving because they're becoming young adults. They're going on to pursue their career. This may seem remote. It may seem, oh, I'm past that. So we're trying to walk a fine line of not diminishing their quality of life by scaring them about it, but encouraging them, you do need to follow up with these things. But the uptake rate of that may be lower than we would like. And so trying to strategize about how to do that better.
Thank you. Thanks for.
Oh, thank you. Appreciate that. Thank you.
All right, our next speaker, Dr. Nicole Christian, who I've known for a long time. Dr. Christian did her undergraduate training at Harvard University and then came back to Colorado to do medical school, and then is a product of our training program at the University of Colorado. She did her general surgery training program here, excelled during residency, and then went to Memorial Sloan Kettering Cancer Center, where she did a breast surgical oncology fellowship. We were able to recruit her back, and she's part of really a breast program that is on the rise, whether you look at academic output or volume, or a new breast cancer fellowship that's coming online, or any metric you want to look at. Dr. Christian has also been very, very active in the well-being space and taking care of our trainees and faculty who rightfully deserve time off to do the other things in life besides taking care of patients all the time. And she has been really a fierce advocate. And many of the policies you actually see on campus and in the Department of Surgery, I can link directly to the work that she has done. And on top of all this, she also is well published, very clinically busy. Just because of the staffing now, she's in the clinics 5 days a week, or operating rooms 5 days a week, and really is teaching our residents how to take care of breast cancer and breast patients. So with that, I'm going to turn it over to you, Nicole. And the topic of her talk is Rethinking Family Leave for Surgical Trainees, Impact of Policy Change and Future Directions. And I'm not going to shake because of the infectious.
Thank you. So I have no conflicts of interest to disclose, except for the fact that I'm very passionate about this topic, and I want to thank all the residents who sent me their baby pictures of their children to include in this talk. I'm going to be talking about parental leave, but I think it's really important to know that this is in the context of a broader idea of family medical leave. And so all of these policies really are under this bigger umbrella of family medical leave, which includes caregiver leave, other types of medical events other than pregnancy. And so while I'll be talking mostly about parental leave, I think it's really important to know that all of these policies truly are beyond just pregnancy and parental leave, but for all of these other things, which we really try to support our residents in. And then I also really need to thank my colleague, Dr. Shannon Acker, who's really been an incredible partner in terms of some of the academic work that we're going to be showing you and how we've studied this actual program and turned it into science. So parental leave policies in general are really complicated. And hopefully today we'll be able to have a bit of an understanding of the overlapping and intersection of state, federal, and also national surgical board policies and ACGME policies. What we've done here for GME around family medical leave, and then what the impact of those changes have been and what some of the next steps will hopefully be. So why is this important? The vast majority of US surgeons ultimately have children. However, female surgeons are more likely to be childless than male surgeons. And so as the population of incoming trainees is increasingly 50-50 men and women, I think it's important for us to really think about these things. Over a third of residents have children during training, so this really impacts a huge number of our residents. And of course, this is because GME training coincides with peak childbearing years. I know we were talking a little bit about fertility issues with the pediatric cancer population, but delaying childbearing, which many of our trainees do, also increases infertility. And so there are higher rates of infertility among surgeons. Female surgeons tend to have fewer children compared to male surgeons. And there are higher rates of pregnancy loss compared to the female partners of male surgeons. So, when people have looked at what is the impact of kind of this landscape on trainees, a huge number of trainees have strongly considered leaving surgical residency. A third of female residents historically would discourage female medical students from a surgical career because of this specific difficulty in balancing pregnancy and motherhood with training. But male residents also really struggle with this, and there's actually some interesting data around how male residents express that they really feel more stigma than female residents report when they take parental leave, because I think of historical culture and pressures around they're not the ones that had the baby, so they didn't get time off. And so in this context of these additional pressures that we have culturally and also medically, in the last several years, there were multiple policy changes that happened in both the training space and also our state legislature that changed what kind of benefits and access our residents and trainees have to family medical leave specifically. So the American Board of Thoracic Surgery followed rapidly by the American Board of Surgery and Vascular Surgery, as well as ACGME changes, created new policies that you can graduate on time without permission from the board, and take more time for family medical leave. Then our state passed a law that guaranteed 12 weeks of paid parental leave. And all of these things happened kind of in rapid succession. And so when I think a little bit about these intersecting and overlapping policy changes, it feels a little bit to me like when some of our colleagues talk about, what I thought of as the coagulation cascade that I learned in medical school versus an actual proteomic metabolomic vision of coagulopathy. And so my goal here is to try to simplify it back to some of those ideas of where actually all of these different policies intersect and impact. And so I'm going to briefly review some of the actual legal landscape, and then talk a little bit about where we have an opportunity to make an impact as a specific department or program. So federal government laws are actually, there's multiple types of laws that can interact with family medical leave. The Pregnancy Discrimination Act is one that I've actually had to learn a lot more about, because you aren't actually allowed to restrict what pregnant women are allowed to do. So when we think of what we offer our pregnant residents to make with their changes, we don't require any of these changes. And I think there's a lot of confusion about what the actual federal Family Medical Leave Act covers. So this is actually unpaid job protection. So this just means that if you've worked at an institution with at least 50 employees for a year, you can't get fired if you take time off for having a child or another family or medical event. But it does not guarantee any sort of pay or other potential consequences. And then, of course, the Affordable Care Act, which expanded access to healthcare, improved a lot of pregnancy outcomes, because obviously a pregnancy is a medical event. And then because of the lack of federal paid leave, a lot of individual states, including our own, passed various state level laws that cover paid family leave. And so in our state, in 2020, there's a kind of requirement that all jobs have a benefit available for paid leave up to 12 weeks. There is a cap on the amount that you could pay. So for any of the attending surgeons in the room, this would not protect your full pay for 12 weeks, but it would at least protect partial pay. And it's that your eligibility for this is much sooner. So our residents are actually, after essentially a couple of days of work in residency, are now eligible for this benefit. And again, this is an expansive benefit that includes not just parental or bonding leave, but medical leave to care for yourself or a family member, including safe leave for domestic violence, which I think is important to always call out, and then military family leave as well. And so most of these reasons would be concurrent with the Federal Family Medical Leave Act, meaning you can't get fired by taking this kind of leave, but this offers some amount of pay protection. And so then what are the actual rules from the ACGME And so this is something that is the obligation of what is referred to as our sponsoring institution, which is the medical school. And so our medical school gives our residents a benefits that have a minimum of 6 paid weeks off for medical, parental, and caregiver leaves. And so our residents have access to this. And so when our residents take leave, there is full pay for a portion of their leave, depending on how much time they take. And similarly then, right, so that now the institution will pay residents salaries for family medical leave, but what's the impact on their ability to graduate on time? And so this is where it can get in the trainee space very complex, because each individual board took these kind of new rules for ACGME accreditation and made slightly different interpretations of how they were going to use it. And so in the American Board of Surgery, you are allowed to take an additional 4 weeks of leave once during the first 3 years and once during the last 2 years, in addition to your normal 4 weeks of leave, because the way that the American Board of Surgery defines training is based off of 48 clinical weeks of activity a year. Now, the vascular surgery, plastics, thoracic surgery, all of that is like urology, all of those have slightly different interpretations of how they define clinical weeks, training. And so what the general surgery residents and the rules we have to follow is not the same as what some of the other trainees in our own department have to follow. And this can then get even more complex when we think about other boards, such as the pediatric boards or the internal medicine boards, or training programs that have very, very different rules about what their board considers to be adequate for training. And so when we go back to, when I was thinking about my role as an associate program director and what I could do to help our trainees in our program, really it became, what can I do here for our residents and our GME? Because obviously I'm not like the president of the United States able to make impact on federal law. And so one of the first things that we did is we did a meta-analysis, and I'd like to specifically thank George Burnett, who helped us with this when he was a medical student and is now an intern in our program. And so we had a team of students who looked at over 1,000 studies. And then of course, there really weren't that many studies that actually had a lot of real scientific data behind it. But we did see that a leave duration of less than 6 weeks was associated with higher rates of burnout and postpartum depression. There's no evidence that parental leave increases attrition. So I think that sometimes there's concern that by taking some leave, residents won't come back. And then, all of this data was published in the era before these new American Board of Surgery rules. And so in that era, before the American Board of Surgery allowed for these additional weeks without extending training, a third of trainees did have to extend training. And I know certainly from my personal experience as a resident, most of my female colleagues specifically took a little bit of extra leave, had to extend graduation, and my male colleagues didn't really take any extra leave because they didn't want to extend graduation. And so when you offer trainees at least 8 weeks of leave, that is associated with higher rates of meeting breastfeeding goals at 6 months post-delivery. And so, when we think a little bit about the landscape of why this is important, the goal of offering more leave is to improve a lot of different well-being measures, and then the board changes that allow us to provide this leave without extending training is really important. And so from this meta-analysis, the real recommendations that we came up with was that policies needed to be formalized with specific considerations for both childbearing and non-childbearing parents, that they needed to allow for a minimum of 6 weeks of parental leave, that there should be promotion of a supportive culture of trainees who take parental leave, and that all members of the program need to be educated on the data and value of parental leave. So that's part of what we're doing here today. And then formal policies also should include resources available for parents to support the return to work, such as childcare and lactation facilities. And I'll talk a little bit more about some of the next directions with childcare and lactation here at our institution. And so the next question we wanted to know is, what's the level of support among surgeon faculty? So we surveyed both MD-DO faculty and also APP faculty. I'll be presenting just the MD-DO faculty data because we just got our APP survey accepted and like a couple of days ago. And so I'd like to thank Dr. Nell Weber who helped us with that. But I will say that the APP faculty data actually exceeds the level of support reported by our MD and DO faculty. And so I think it's really, because that's important to mention, because so many of our APP faculty are impacted by some of our, leave policies when our residents are gone and the team needs to deal with a team member who might not be there, or we're, shifting things around, our APP faculty are greatly impacted. So I think it's critically important to mention and thank all of our APP faculty for being so supportive. So we did a web-based survey of faculty at multiple academic institutions, including our own, and we thought that there would be differences based off of the timeline of training, so more recent graduates, and then also whether or not the respondent had children, about what level of leave they supported. And so one of the questions that we asked was, to what extent did you feel supported by the faculty at your program to take leave? And so faculty reported not feeling particularly supported when they took leave, which is not surprising. But I thought it was really great to see that, 77% of the current trainees that we surveyed did report feeling supported. And so I think that that means that there is culture change happening. And so this is a fairly busy slide, but I think what's really important to highlight here is that the majority of respondents, whether or not both current faculty and current trainees, and with no difference whether they had children or not, thought that 6 to 12 weeks was the best amount of time to take after having a child. And then whether or not they thought time for maternity leave puts an unreasonable strain. Again, this was a little bit surprising to us, but over 60% of respondents, both faculty, current trainees, whether or not those faculty or trainees had children, did not feel that it was an unreasonable burden for people to take leave, which I think is one of the cultural barriers that trainees frequently report and is reported in the literature, that's one of the big things that trainees worry about, is that it's putting an unreasonable burden on their trainees. And then also, a huge majority, a pretty substantial portion of the respondents reported that they didn't actually know what the current leave policies were at their institution. And so I think this is also part of what this is helping everybody, at least at our institution, know what the various policies are. And so similarly, when you look at when we looked at time of training, it was very consistent that opinions on childbearing and between childbearing and non-childbearing parents and parental leave, faculty very consistently, regardless of timeline of training, really did support at least 6 weeks of leave for our trainees, which I think is really great for our trainees to hear. And I put up this slide not just because I think that there was a qualitative aspect to this study that we did. And I think some of these quotes and themes are really important to highlight, especially around the idea that there is not an unreasonable strain to allow people to take medical leave or to take family and medical leave. And so we took our own data, but also then the data available in literature, and we developed a working group in our own department with faculty. We had residents who were both parents, non-parents, men and women, our program coordinators to help us make sure we were following the rules, and then representation from multiple sites in our own program. So not just the university, but Denver Health, the VA, Children's. And we kind of did a process of reviewing our own cultural norms, what we thought was realistic, what some of the logistical challenges would be to support family medical leave, what our various site-specific resources were, what the trainee perspectives were, and then really tried to create an evidence-based series of guidelines so that we could offer our residents who are pregnant or having children a real clear understanding of the expectation, because again, the specifics I think are less, the data supports that specifics of your policy are actually less important than it being explicit and everybody understanding them. And so in general, when we have a resident who's going to need a family medical leave, they essentially meet with me and we talk about, what is the duration of leave that they can take, both how is that going to be paid and whether or not that's going to impact their ability to graduate on time, and whether or not that would impact their ability to sit for their boards on time. And so I will say that anecdotally, 100% of our residents have taken the maximum amount of leave that they have available to them without delaying graduation. And some of our residents have elected to delay graduation because of their specific situation. But nobody has yet taken a leave that's impacted their ability to start their fellowship or take their boards on time. And so some of the other strategies that we use in our program with our policy are, again, education. So part of when a resident takes a family medical leave and they meet with me, I go over some of these rules because I think sometimes it can feel really unfair when you find out that your spouse who's a pediatric resident might get additional time or be able to stack research months onto their leave that kind of functionally extends their leave. but we don't because of some of the rules that the American Board of Surgery has. And so kind of working through that educational piece. We do make schedule adjustments for both pregnant, for any new parent, whether they were the childbearing parent or not. And then also a lot of the process details. Who do you contact in the GME office to get these benefits? What does that look like? What paperwork do you need to fill out? You know, Brittany Reyes, who our coordinator, works with our residents all the time about the state family paperwork. It's, you know, it's really complex. And then we also work to try to assign a faculty mentor so that as the resident progresses through becoming a new parent, they have somebody that they can reach out to commiserate, to ask questions, to ask for help. And then we also, it's a way to kind of softly open the door for special circumstances. We've had residents who've had infertility, miscarriage, who've needed to get IVF, who have had high medical need pregnancies, or babies who've had extended, prolonged NICU stays. And so what if that were happening, what that might look like. And then again, really for the culture change piece, explicit language around, you know, that our program supports any amount of leave that our trainees want to take, really focusing on equity so that all of our trainees feel supported. And then what kinds of, you know, and then incorporating discussion of this into faculty and resident education. So thank you for coming to the Screen Rounds. So the first year that we had that the new leave policies were available, so we had residents who were able to take much more leave than they were in the past. We had 13 family medical leaves, which was a lot considering historically. So the red are the medical leaves that we had the very first year, and then the yellow is like the cumulative collective number of parents we had in the program before this 1 year. And so you can see that I think we just had, I don't think that the new policies were why people had babies, but I think that the point is that, you know, we kind of tested the system pretty significantly the very first year by having so many residents that took leave, and, you know, the residency survived. And so I think, you know, we really wanted to ask, and again, we really wanted to ask, you know, what was the impact of this on our trainees? So we did a pre-survey before we instituted this new policy and these new leave, national leave policies went into effect. And then we did a post-implementation survey. And again, we looked at residents, men versus women, residents that had children or didn't have children. None of that ended up being statistically significant. And what I'd like to highlight here is that in every single metric that we ask our residents about in terms of equity, fairness, understanding, we improved our residents' experience of pregnancy throughout the program, again, with no difference between residents who had children or didn't have children, men or women. The only metric that we didn't really change is how residents felt about the question, pregnancy is a risky medical condition for surgeons, which I wouldn't necessarily expect for that to be something that changed, because the reality is it is, and I hopefully with some of these changes nationally, we'll be able to make some headway on that. And so after we implemented our policy successfully, I was asked by the Associate Dean of GME to create a GME toolkit so that we could kind of implement our process and strategy and what we learned across GME. And so now we have, you know, there's hundreds of programs, over 1,300 trainees at this institution. And from a family medical leave perspective, we get 70 to over 90 family medical leaves a year. And so we kind of deconstructed our process and tried to make it a little bit more accessible. And so now all programs at CU have access to this toolkit so that they can use it themselves. We'll be presenting this toolkit at the ACGME meeting just next month. I also, because of this work, was asked by Dr. Lottie Derby, who's the dean, you know, our associate dean of wellbeing, to put together a series of recommendations in what we referred to as a family-friendly advisory committee with Dr. Annie Moore, who's a professor in internal medicine. And we came up with this organizational framework to identify, like, really what's the difference between a compliant organization and something that's really a national model of, you know, transformative policies around family-friendly policies, which would include caregiving for elderly parents. You know, frequently, I think some people in my generation get referred to as a sandwich generation, where there's elderly parents with medical needs, young children with a lot of needs, just being children, and then also trying to like have busy careers. And so CU and, you know, really as an institution has some things, you know, is kind of, there are things scattered throughout, right? Like no one institution is going to fit specifically in any one area. And so this is something that we hope will start to continue to percolate up institutionally, again, outside our department. So what are some of the ways that we can, what are some of the things I anticipate to be changes both nationally and then potentially in our program. So one, I think curriculum changes. So specifically in pediatrics at this, on this campus, they have for a long time been really innovative, and they've created structured curriculum that are approved by their board that new parents can take, one of which is essentially care of the healthy newborn, right? So there's a curriculum, they have to do work, but they take care of their own child and they get actual residency credit for that. Now, obviously, that's appropriate for a pediatrician, not necessarily for surgeons, but they also have created a lactation elective. And so, I think that there are potentially opportunities for us to have truly appropriate for surgeon electives that we could consider trying to pilot or model. And then also, I think long-term, as we move to competency-based assessments, some of these questions about leave, what the impact on training is, if there's not necessarily a fixed number of time, right? 5 years means everybody's the same kind of surgeon, but it's a true competency-based evaluation of when we deem trainees to be competent, then some of the flexibility in training can, I think, open new opportunities for what that might look like for parents. Recently in JAMA surgery, there was kind of an expert opinion about what types of policies departments should have to support pregnant surgeons. And I was very happy to see that our department is very much in line with all of those, except there were some interesting comments about ergonomics. And I know we've talked about ergonomics for all surgeons in this in grand rounds previously. But when coming up with any sort of like ergonomic approach to supporting surgeons from a physical safety perspective, considering how pregnancy actually does change some of the, changes the pregnant individual's bodies and what that might mean. And then with lactation, this is a really, really big challenge and continues to be. The AAP recommends 2 years of breastfeeding, which is a policy, which is a recommendation that they changed about 2 years ago in the middle of a formula shortage. And to breastfeed a child for a year takes about 1,800 hours. And that's obviously an average. Some women might need to spend more time to sustain physiologic breastfeeding. Some women might need less. And, I didn't learn any of this, by the way, at my breast fellowship at Sloan Kettering. I learned all of this from my own personal experience. And so maintenance of physiologic breastfeeding happens every 3 hours. And so when we think about some of our trainees who are trying to maintain breastfeeding, who have breastfeeding goals to be compliant with the AAP recommendations for 2 years, that's an incredible burden. And I think, when, all of our institutional partners and hospital partners are compliant with federal law in terms of accessibility, with the minimum amount of lactation space, but there's a huge number of things that we can do for our trainees to make it not just the minimum requirement, but like truly culturally acceptable, accessible. And, if you think about the size of our campus, walking 15 minutes to a lactation room in order to pump for 20 minutes and then 15 minutes back, that's just an incredible amount of time. And what can we do, thinking about what we can do when trainees who are trying to maintain their breastfeeding goals ask to step out of the operating room for a short period of time. And then the other thing that I just like to acknowledge is childcare. I think this is a huge issue for all of our trainees. I think it's a big issue for any parent in the current society. And again, this isn't something that a program can necessarily change, but there are a lot of, really meaningful issues that our trainees experience. And I think I want to say to all of our trainees who are listening, who are parents, like, this is exceptionally hard. And you guys are all really great parents. And I'm really proud of all of you. The last thing that I'm going to mention is this 4th trimester initiative, which is an MGH-sponsored initiative of a parental support package for residents who are pregnant. And the goal is to kind of improve some of these after you have the baby experiences. And they did a pilot in the Northeast with MGH and a couple of other regional programs there, and showed really impressive sustained decrease in burnout with this parental support package. And so we are likely going to be a site for them in a randomized controlled trial. This is for all of GME for this parental support package. And so as we get through kind of the regulatory process and get everything, set up for that, that's something for you all to look for me in the future. And so, this type of work is incredibly, something that a huge amount of work goes into. I really need to thank all of the leadership in this department who supported all of this work, all of my, all of the many collaborators I've had across the country who've helped come up with these policies and study them. Like I said, all of the residents. I'd also really like to thank my parents. My mom is actually here in the audience. They had me when they were in training. My mom was chief resident of pediatrics and was attending on the wards 2.5 weeks after her C-section. And my dad got, 0 time off. And so they're have been incredibly supportive of my entire career. And then, of course, my husband and my children who are, I care about deeply as well. And so thank you all for letting us do this work with our residents. And I think we're at time. So thank you again.
I think we'll hold on questions and comments. Other than, thank you so much for taking the bull by the horns and getting stuff done in this arena. So we all very much appreciate it. And everyone have a great week. Email or call Dr. Chris